Greetings, I'm the dentist. Welcome back to DENTAGENDA. This is Chapter 4, Orthodontics. In this tutorial, you will learn about different aspects of cephalometric radiographs in orthodontics. These are the points we're going to discuss throughout the tutorial. To begin with, we will define the word cephalometrics. Cephalo means head, and metrics means measuring. So, the word means the recording and interpretation of measurements of the skull made on standardized radiographs of a living head. General clinical applications of cephalometrics in dentistry includes the following. It can be used to analyze the dental and skeletal relationships of a human skull. Also, it is frequently used by dentists, orthodontists, and oral and maxillofacial surgeons as a treatment planning tool. It can be used to study the relationships between bony and soft tissue landmarks and to diagnose the facial growth abnormalities prior to the treatment, also in the middle of the treatment to evaluate the progress, and at the conclusion of the treatment to ascertain that the goals of the treatment have been met. Although it might not be necessary for a dentist or an orthodontist to know the specific parts of the machine or the terminology of the physical parts, but it's also good to touch upon the main parts of the machine. It includes the collimated X-ray source that is placed 5 feet from the mid-sagittal plane of the patient, the cephalostate, which is the head positioner. It has 2 ear rods that can be inserted into the ears of the patient and a forehead clamp to stabilize the forehead in the place. The aluminum wedge or barium paste to increase the soft tissue definition in the film when it's printed, and the film itself that should be placed from 1.5 to 1.8 feet behind the mid-sagittal plane of the patient with rare earth metal intensifying screen. Here is a close-up of the cephalostate, which is the head positioner. It includes the 2 ear rods. These are inserted in the external auditory meatus of the patient and the forehead clamp that stabilizes the head in the correct position. Now, in case you were the one that are going to help the patient to stand in the machine and you're going to take the X-ray, you should know the correct position of the patient. Firstly, the Frankfurt horizontal plane that we are going to discuss later on this tutorial should be parallel to the floor. Also, the ear rods stabilize the patient on the horizontal plane, so make sure to insert them into the external auditory meatus of the patient. The forehead clamp should be fixed for the patient's vertical plane stabilization, so that the patient shouldn't tilt their head to the right or to the left. And finally, the patient is instructed to close the mouth in centric occlusion and to stand still throughout the process of the X-ray taking. There are different types of cephalograms. Each is taken from a different angle and shows a different side of the human skull. And also, each is used to assess different relationships between different structures depending on what is being visible in each view. So we are going to go through them all one by one. Number 1. Lateral cephalogram. Hence the name, it is a side or a lateral view of the head and face, rather than the front or the back. It is commonly used by orthodontists to assess the position of the teeth and jaw in relation to each other and to the rest of the face. And this is the view we are going to go through the analysis of it throughout this tutorial. Number 2. Frontal cephalogram. This is a frontal view taken to assess the position of the structures falling in the front side of the face and their relationships with each other, such as the front teeth, the front part of the jaw, and the nasal bones. Number 3. Posterior-anterior cephalogram. This is a front-to-back view of the head and face, taken with the patient facing the X-ray source, which can be helpful in evaluating the anterior teeth, the jaw joint, and the airway. Number 4. Basal cephalogram. This view of the head is taken from the base of the skull. It is used to assess the position of the structures falling in the basal side of the head and their relationship with each other, including the lower jaw and its relation to the rest of the face. Number 5, the standard cephalogram, which is the same as the view of the lateral cephalogram. It is used to assess the overall shape and size of the face and the skull. Number 6, profile cephalogram. This is an essential view for assessing the profile and the overall shape and size of the face and is commonly used during any orthodontic treatment or orthodontic surgery. Number 7, 3D cephalogram. This type of cephalogram is a three-dimensional image of the head and face that is created using advanced imaging techniques such as CT, MRI, or CBCTs. It provides a highly detailed image of the head and face, which can be used to study and assess the position and shape of the teeth, jaw, and skull with accuracy. 3D cephalograms are often used for planning orthodontic surgeries as they provide detailed information about the patient's dental and skeletal anatomy. Cephalometric tracing and analysis can be done by one of two methods, either manually or computerized using artificial intelligence-based cephalometric tracing and analyzing softwares on the computer or mobile apps. For the manual tracing of the cephalometric film, you will need the following. Acetate tracing paper, which is the transparent paper that allows you to see the structures of the film underneath and to trace the outline of them. The sheet size corresponds with the film size, which is 210 mm by 160 mm. A viewing box, which is the light source. It allows you to see the structures in the film and to trace them easily. A protractor to measure the angles. A ruler to measure the lengths. Adhesive tape or stapler to attach the acetate paper to the film so it doesn't move. An eraser, an HB or 4H lead pencil, and colored pencils to mark different points or landmarks. Step number 1. Perfectly align the tracing paper on the lateral cephalogram film. Step 2. Overlay the sheet of acetate tracing paper on the radiograph and attach the top edges with adhesive tape or pins so it doesn't move. Step 3. Draw two crosses about 3 centimeters apart on the corner of the radiograph so they will be the reference for you for the ease of subsequent superimposition. position of the tracing. Step 4. Write the patient's name, age, and date of the radiograph on the top corner. So in case of detachment of the tracing paper from the film, you can easily identify the case. Step 5. Place the radiograph with the overlying tracing paper on the light view box and use your pencil to trace the anatomical landmarks and points we are going to mention shortly. The other method for tracing and analyzing cephalometric radiographs is the automatic tracing or computerized tracing. In this method, you can use fully or semi-automated artificial intelligence-based computer software or mobile phone apps. Now to the landmarks you need to trace before you start measuring. Trace the soft tissue outline of the face, then the bony forehead and nasal spine. Then trace the orbit and the cranial base. Also trace the pterygomaxillary fissure, the external auditory meatus, and the base of the occipital bone. Also trace the mandible and the maxilla, the upper and lower central incisors following the correct long axes, and trace the upper and lower first permanent molars in relation to each other. Now to the point we mark on the lateral cephalometric film. Know that each one is designated with a letter or two letters. So we will say the name, and the letter between the parentheses is what you really use on the film or the tracing paper, or even to write down your measures. Sella, it is the midpoint of sella turcica or the pituitary fossa. Nasion, the midpoint of frontonasal suture. Porion, the top of external auditory meatus. Orbitale, the inferior border of the orbit. Pterygomaxillary fissure is the most posterior and superior point on the pterygomaxillary fissure. Condyloin, the most superior point on the head of the condyle. Articulare, it is the point on the posterior border of the ramus at the intersection with the basilar portion of the occipital bone. Posterior nasal spine, PNS, it is the posterior point of bony hard palate. The ANS is the anterior nasal spine, and it is the anterior point of the maxilla. The A point is the deepest point on the maxilla below the ANS. B point is the most posterior point on the bony curve of the mandible above the pogonion. Pogonion is the most anterior point of the bony chin. Gnathian, the most anterior inferior point on the bony chin. Menton is the lowest point on the symphysis of the mandible. Gonian, the most posterior and inferior point on the outline of the angle of the mandible. And the Bayesian is the most inferior posterior point on the occipital bone that corresponds to the anterior margin of the foramen magnum. The previous points were the skeletal or the hard tissue landmarks. Now to the dental landmarks. They include 4 points. The upper incisor apex, which is the root apex of the maxillary central incisor. The incisor superius is the tip of the crown of the maxillary central incisor. The incisor inferius is the tip of the crown of the mandibular central incisor. And the lower incisor apex is the root apex of the mandibular central incisor. These help you to draw the long axis of each incisor later on in the measures. Now to the soft tissue landmarks. You will find that some are pointed to by different letters than the hard tissue corresponding structures, and some of them are assigned by the same letter of the corresponding hard tissue structure, but with a dash on top of the letter. So when the dash is present on top of the letter, you know we are pointing to the soft tissue structure. Starting with the soft tissue glabella, which is the most prominent point in the sagittal plane between the supraorbital ridges. Soft tissue nasien is the deepest part of the soft tissue outline in front of nasal. Tip of the nose, or called the pronasale, designated by the letter P. Subnasale is the junction of nasal septum and upper lip in mid-sagittal plane. Soft tissue A point, or superior labial sulcus, or upper labial sulcus. It is the deepest midline point on the outline of the superior labial sulcus. Labialis superior is the most anterior point on the outline of the upper lip or vermilion border. Stomium superior. It is the lowest midline point on the outline of upper lip. Stomium inferior is the highest midline point on the outer line of lower lip. Labialis inferior is the most anterior point on the outline of the lower lip or lower vermilion border. Soft tissue B point, or the inferior labial sulcus or lower labial sulcus, is the deepest midline point on the outline of the inferior labial sulcus. Soft tissue pogonian is the most anterior point on the outline of soft tissue chin. Soft tissue menton is the lowest point on the outline of the soft tissue chin. Soft tissue facial plan is a line connecting the N, soft tissue nasien, and the soft tissue pogonian. H-line, or the holdaway plane. It is a line between pogonian dash, which is the soft tissue pogonian, and a tangent to the upper lip. S-line, it extends from pogonian dash, which is the soft tissue pogonian, to midline of an S formed by a lower border of the nose. The E-line, or aesthetic plane, in Reckitt's analysis, it is extended from pogonian dash to the P point. After you're done pointing the hard tissue, the dental, and the soft tissue points, now it's time to connect some of them to form some important planes. Some of them are horizontal and others are vertical. Starting with the horizontal planes. The SN plane, it extends between the S and N, sella and nasien, sitting at the anterior cranial base. Frankfurt horizontal plane. It extends between porion and orbitale. Y-axis, or the growth axis, extends between sella and nathian. Palatal plane extends between anterior nasal spine and posterior nasal spine. Occlusal plane. Now the occlusal plane depends on the occlusion of the patient. If the patient can achieve functional occlusion, then the occlusal plane will extend between the maximum intercuspation of the sixes and the midway of the overjets. In case of not achieving functional occlusion, like in case of open bite, it will extend between the molars and the premolars. Finally, the mandibular plane. There are different types of analysis. We are going to discuss them at the end of the tutorial. In each one, it extends between two different points. So, for example, in Down's analysis, the mandibular plane is considered to be extending between the gonian and the menton. In Tweed's analysis, however, the mandibular plane is a tangent to the lower border of the mandible. And in Steiner's analysis, the mandibular plane extends between gonian and gnathian. Now to the vertical planes. Starting with the long axis of the upper and lower central incisors. Each of them can be easily drawn by connecting the 2 points you have pointed before, the one at the apex and the other on the incisal edge of each one. The lower anterior facial height extends from the anterior nasal spine to menton. Posterior facial height extends from sella to gonian, and total facial height extends from the gnasian to menton. Facial plan is a vertical plane connecting gnasian to begonian. E-line or aesthetic line is a line between the most anterior point of the soft tissue nose to soft tissue chin. The holdaway or H-line, it is a line between the outer prominent surface of the upper lip or a tangent to the upper lip to the soft tissue chin. Finally, after pointing all the skeletal, dental, and soft tissue points and connecting some of them to form many horizontal and vertical planes, you will pretty much end up with something looking like that before we're starting to measure some lengths, percentage, or angles. Now we are going to go through some tables in which I have collected the most commonly used skeletal, dental, and soft tissue angular and linear measures, and their interpretation as well. Note that there are many other measures in different analysis systems, but in this tutorial we will focus on the following only. Also note that the mean values mentioned here may vary from one system to another and from one population to another, and it has a plus or minus a specific number of units known as standard deviation, among which the result is considered to be normal. Skeletal measures. SNA angle. The mean value is 82 with plus or minus 2 as standard deviation. It indicates the maxilla, prognathism, and retrognatism, and it allows you to decide the skeletal class of the patient, whether it's class 1, 2, or 3. When it increases, it indicates maxilla prognathism, and when it decreases, it indicates maxilla retrognatism. The illustrations on the right are small because they are fitting in the cells of the table, so you can zoom in to see it clearly. The SNB angle, the mean value is 79, and it indicates the mandible prognathism or retrognatism, also allows you to decide the skeletal class of the patient. If it increases, it indicates mandible prognathism, and if it decreases, it indicates mandible retrognatism. The ANB angle, which is the difference between the SNA value and the SNB value, it ranges from 2 to 4 degrees, and it indicates the skeletal class of the patient. Of course, the same goes on the ANB. If it increases, it means that the patient is skeletal class 2, and if it decreases, it indicates a skeletal class 3 tendency. Lower facial height. This is a linear two measures that are divided by each other and then multiplied by 100 to give you a percentage. The first value is the lower anterior facial height, which extends from the ANS, which is the anterior nasal spine, to the menton, divided by the total facial height, which extends from the nasion to the menton, and the value is multiplied by 100 to give you a percentage. The mean value here is 57%, and it indicates the growth pattern of the patient. If it increases, it indicates that the patient is a vertical grower, or we can call it a high angle face, and also in some cases it can be seen as a dental presentation, which will be an open bite. And if it decreases, it indicates that the patient is a horizontal grower or a low angle face, and sometimes dentally it can be seen as a deep bite tendency. Posterior facial height. It is the result of dividing the posterior facial height, which extends from the S to gonian, divided by the total facial height that extends from the nasion to menton, multiplied by 100, and the normal value is 66. Also indicates the growth pattern. If it is less than the mean value, it indicates a vertical growth, and if it is more than the mean value, it indicates horizontal growth. Angle between the SN plane and the mandibular plane. And here we are using the Steiner's mandibular plane that extends from the gonian to nathian. The mean value is 32. It indicates the growth pattern. If it increases, it indicates vertical growth. If it decreases, it indicates horizontal growth. The angle between the Frankfurt horizontal plane and the mandibular plane. Mean value is 25. If it increases, vertical growth. If it decreases, horizontal growth. The angle between the y-axis that extends from the cella to Nathan and the Frankfurt horizontal plane that extends from the porion to orbitally. Mean value is 61 degrees, and it indicates the growth pattern as well. If it increases, indicates vertical growth. If it decreases, it indicates horizontal growth. Gonial angle. It is the angle between articulary, gonian, and Nathan. Mean value is 124. If it increases, it indicates vertical growth or high angle face, and if it decreases, it indicates horizontal growth or low angle face. The angle between palatal plane that extends between the anterior nasal spine and the posterior nasal spine, and the mandibular plane. Mean value is 23 degrees. If it increases, it indicates skeletal open bite, which can be translated as a high angle, and if it decreases, it indicates skeletal deep bite, and that can be translated skeletally as low angle, horizontal growth. Because sometimes you should know that not every vertically growing face will have an open bite, and every horizontally growing face will have a deep bite. Of course not. Sometimes it can be both, and sometimes it can either be skeletally or dentally. Facial plane angle. It is the angle between S and Pygonian. Normal value is 80 degrees, and it indicates the mandible position. If it increases, it means that the mandible is set in a more forward position, and if it decreases, it means that the mandible is setting in a more backward position. Facial angle. It is the angle between the Pygonian and Frankfurt horizontal plane. Mean value is 87 degrees. If it increases, if it indicates mandibular prognathism, and if it decreases, it indicates mandibular retrognathism. Angle of convexity extends between NA plane and Pygonian A plane. The mean value is 4 degrees. If it increases, means that the face or the profile is convex, and if it decreases, it means that the face is concave. Also, note that it can be a positive or a negative value depending on the positions of the two planes. If the Pygonian A plane is anterior to the NA plane, then it is positive, and if the opposite, it will be negative. Also, when you're zooming on the photos, note that we are always, almost always, measuring the internal angles, like the angles pointing towards the middle of the face. Also, when you're memorizing or knowing the values of some angles, it will help you to decide which angle of the 4 angles, or you can say 2 angles, results from the intersection of the planes is the correct one, so you're not having them mixed up. Cranial base angle is the angle between Nasion, Sella, and Bayesian. Mean value is 132. If it increases, it indicates a true skeletal class 2, and if it decreases, it indicates true skeletal class 3. Angle between SN plane and palatal plane. Mean value is 9 degrees. If it increases, it indicates deep bite or low angle face, and if it decreases, it indicates skeletal open bite or high angle face. Maxillary length, or the midfacial length. It extends from the condyle line to point A. The values are taken from the McMurray chart. mean value here is 91 millimeters. That indicates the size of the maxilla. The mandibular length mean value is 120 millimeters, and it also indicates the size of the mandible. Bony chin extends from the NB line or plane to pogonian. Normally it is 2 millimeters, and it indicates the prominence of the chin. Total chin is the bony chin that extends from a line from N to B, and its distance from the pogonian, plus the soft tissue chin that extends from the hard tissue pogonian to soft tissue pogonian. The total mean value is 16 millimeters, and it also indicates the chin prominence. Width appraisal, it can be measured as follows. You line a perpendicular line from point A to the occlusal plane, and then you draw another perpendicular line from point B to the occlusal plane, and you measure the difference or the distance between these two lines. It should be from 0 to 1 millimeters, and if the patient is a class 2 skeletal class 2, the AO line will be located ahead to the BO line, and the width appraisal value will be positive. On the other side, in class 3 patients, the BO line point will be located ahead or in front to the AO line, and the width appraisal value will be negative. Now to the dental measures. The angle between the upper central incisor and Frankfurt horizontal plane, the mean value is 112, and it indicates the upper incisor inclination. If it increases, it means that the upper incisors are proclined, and if it decreases, it means that the upper incisor is retroclined. The angle between the lower central incisor and the Frankfurt horizontal plane, mean value is 59 degrees, and if it increases, it indicates retroclination of the lower incisor, and if it decreases, it indicates proclination of lower central incisor. The angle between the lower central and the mandibular plane, mean value is 95 degrees. If it increases, the lower incisors are proclined. If it decreases, the lower incisors are retroclined. The interincisal angle, which is the angle between the long axis of the upper central and the long axis of the lower central, mean value is 127 degrees. If it increases, it means that there is a small overjet, and if it decreases, it means that there is a large overjet. The distance between the upper central incisor tip and a line extending from the A point to the pogonian, normally it is 4 millimeters. If it increases, it means that the upper incisor is proclined, and if it decreases, it means that the upper incisor is retroclined. Dental Steiner analysis. The angle between the upper central long axis and the NA line, mean value is 24 degrees. If it increases, proclination. If it decreases, retroclination. Same for the lower central incisor. The angle between its long axis and the line extending from the end point to the B point, mean value is 27. If it increases, it indicates proclination, and if it decreases, it indicates retroclination. The distance from the upper central incisor and the line extending from the N to the A point in millimeters. The distance should be measured perpendicularly, of course. Mean value is 5 millimeters. If it increases, it indicates proclination, and if it decreases, it indicates retroclination. Then the distance between the lower central incisor and the NB line. Mean value is 6 millimeters. If it increases, it indicates proclination, and if it decreases, it indicates retroclination. Tweed triangle. Tweed triangle is a triangle formed by the intersection of three lines. The first one is the Frankfurt horizontal plane extending from the orbitale to the porion. The other line is the long axis of the lower central incisor, and the third line is the mandibular plane. And in Tweeds, it is considered as a tangent to the lower border of the mandible. The intersection forms a triangle with three angles. The first angle is formed by the Frankfurt horizontal plane and the mandibular plane. The other is formed by the mandibular plane and the long axis of the lower central incisor. And the third angle is formed by the intersection between long axis of lower central incisor and Frankfurt horizontal plane. As you can see, each one of them has a mean value. But what matters and what makes you check if your measures are correct or not, the sum of the three angles should always be 180 degrees, because the sum of the internal three angles of any triangle should always be 180 degrees. Soft tissue measures. H angle. The H angle is formed by two lines. The first one extending from the soft tissue nasien to the soft tissue pygonian, and the other extends from the soft tissue pygonian to the most prominent point of the upper lip, which is a tangent to the upper lip. Mean value is 10 degrees. If it increases, it indicates that the profile is convex, as in class 2 cases. And if it decreases, it indicates that the profile is concave, as in class 3 cases. The distance between the upper labial sulcus and the H line, of course, measured perpendicularly on the H line. Mean value is -6 millimeters, means that the sulcus should normally set behind or posterior to the H line, so the negative is the normal value. The distance between the lower labial sulcus and the H line, normally it is -5 millimeters. Also, the lower labial sulcus should always be behind the H line. The lower lip to the H line, normal value is 1 millimeters, and it should be positive. So normally the lower lip extends about 1 to 2 millimeters in front of the H line. The tip of the nose to the H line, normally it is about 8 millimeters. Facial angle. It is the angle formed by the Frankfurt horizontal plane and a line extending from soft tissue nasien to soft tissue pygonian. Mean value is 91 degrees. Nasolabial angle. It is the angle formed by a tangent to the columella or the nose base and the upper lip. Mean value in males ranges between 90 to 95 degrees, and in females ranges between 95 to 115 degrees. If it increases, it indicates retrusion of upper incisors, so the sulcus or the nasolabial angle will be obtuse. And if it decreases or becomes more acute, it means that the upper incisors are proclined. Mentolabial sulcus. It is formed by a tangent to the lower lip and the surface of the soft tissue chin. Mean value ranges between 107 to 118 degrees. If it is increasing, it indicates retrusion of lower incisors, and the mentolabial sulcus will be shallow or more obtuse. And if it decreases and becomes more acute, it means that the lower incisors are proclined. Last but not least, we are going to get to know some different analysis systems and have a brief idea about each one of them. Downs analysis. It depends on the Downs occlusal plane. This plane is formed by bisecting the anterior incisors and the distal cusps of the most posterior in occlusion. It has 10 parameters to be measured. 10 of them are skeletal and the other 10 are dental. Steiner analysis. He used the SN plane as his reference line in comparison to Frankfurt horizontal plane, due to difficulty in identifying the orbitali and borean in some lateral cephalometric foams. Witts analysis. Note that the other analysis systems are named after orthodontists, but Witts analysis actually is named after the Witwatersrand Johannesburg University in South Africa. Witts analysis is a measure of the extent to which maxilla and mandible are related to each other in anterior-posterior sagittal plane. As we have learned, we draw a perpendicular line from point A to the occlusal plane and another perpendicular line from the B point to the occlusal plane, and we see which one of them is ahead to the other to decide if it is a class 2 or a class 3 dentition or skeletal form. Tweed analysis, describing the lower incisor position in relation to the basal bone and the face. And remember, we have discussed the Tweed triangle that is formed between the three different lines. The Frankfurt horizontal plane, the long axis of the lower central incisor, and the mandibular plane. And in Tweed's analysis, it is a tangent to the lower border of the mandible, and the sum of the internal three angles should always be 180 degrees. Ricketts analysis. It is one of the most important methods in assessing, tracking, and diagnosing routine patient growth pattern in craniofacial complex. It is also helpful in determining the vertical, transverse, skeletal, and dental problems and emphasize the growth and facial pattern. The mean measurements given are those of a normal 9-year-old child, and the tables of Ricketts analysis shows how much does it normally increase or decrease as the patient ages, and some measures, of course, can stay the same. McNamara analysis. McNamara's research focused mainly on clinical modification of the growth of face and jaw. Craniofacial skeletal complex is divided into 5 major sections: maxilla to cranial base, maxilla to mandible, mandible to cranial base, dentition, and airway. Fold-away analysis. It involves measuring 11 specific soft tissue landmarks and relationships to determine if a patient's face profile is balanced and harmonious, or if orthodontic treatment is needed to improve facial aesthetics. So mainly it is concerned with soft tissue. And by that we have covered all the points for this tutorial. See you in the next one.
Thank you for watching. Don't forget to subscribe. I'd like to have you here for more videos. And follow us on Instagram at DENTAGENDA for extra tips and tricks.